You're good.
So I think some of you know me, probably through the numerous emails that I send through Serve and through the actual MFT group, but my name is Cheryl Donald. I'm a licensed marriage and family therapist, and I also serve as the president-elect of Metro Chapter. And in my other life, which is the majority of my life, I work for the federal government for the Health Resources and Services Administration, which is one of the octaves of the U.S. Department of Health and Human Services. And so HRSA, as we're called, because our name is so long, primarily focuses in on providing care for the uninsured and the underinsured. So our programs include community health centers that you may be familiar with. We also do the Ryan White Care Act funding. We provide block grants to states for maternal and child health funding. And we also provide funding for organ donation. So we actually manage those grants. So when you sign up on your donor card, we manage that program as well. And we also provide scholarships and loan repayment for mental health professionals, MFTs included, as well as MDs, dentists, etc., who are willing to work in what we consider underserved areas. And so those underserved areas can be urban areas, such as some areas of New York City, and also in rural areas throughout the country. And so there's an opportunity, if you're interested in that, you can talk to me about it later, in having some of your loans repaid, in addition to your salary if you work in an area that's considered a health professional shortage area. Okay? So that's a very brief overview of the agency, but the point today is to really talk about the Affordable Care Act, Obamacare, if you all have heard on the news, and also about the healthcare marketplace. And I know that if you all, well, how many people live in New York? Does everyone live in New York? Okay. So I'll speak specifically about New York, but if you all know anyone, I know we have some members who actually live in New Jersey but actually practice in New York. There's a different caveat for how you sign up for the health insurance piece, whether you live in New York or New Jersey. So what I thought I would do today is just to give you an overview about what the ACA is, because I think we all hear about it. I know what it is because I work in HHS, but I think most people are confused about what the ACA actually is. Some people think Obamacare is something different than the Affordable Care Act. I don't know if you all saw that little skit on late night, and it's like, well, what do you like, Obamacare or the Affordable Care Act? People are like, I hate Obamacare, but I love the Affordable Care Act. So it's kind of like the same thing. Obamacare is just a nickname that the Republicans actually gave to the legislation, and then the Obama administration just kind of adopted it and said, hey, we're going to roll with it. And so that's why you hear it interchangeably. So let's just talk a little bit about what the Affordable Care Act is. We'll talk about signing up for health insurance and what happens if you don't have health insurance and you're not signed up. And then also we can talk a little bit about how this impacts on us as MFTs and our practices and how it may impact on some of our clients, okay? So since we are in a nice cozy room with no AV, hopefully everyone has the PowerPoint presentation, and actually it's kind of good that we were able to print this out because you can take it with you. So we're going to kind of go through this presentation, and if you have questions as I go through it, please just raise your hand and let's just try to make this interactive, and I don't want to be lecturing you all this morning. It's too early for a lecture. So again, the Affordable Care Act, what does it do? It actually strengthens the private insurance for consumers, and then it also creates a marketplace in each state where people can actually sign up for health insurance and get coverage. It also provides financial help for people that cannot afford health insurance or for whom the premiums may be expensive. And then it also gives the states an opportunity to actually expand their Medicaid program so that more people are actually eligible for Medicaid in each individual state. And for those of you who may not be familiar, the way the Medicaid program works is actually run by individual states, and the federal government matches it dollar by dollar. So if the state puts in $1, the federal government will put in $1 to match that. So that's how it works. So the states decide how the program runs, they decide the size of their program, there are minimum requirements that they have to meet, but after that, if they want to cover more people, they can do that. It's really the state's prerogative. So that's why there may be some differences in Medicaid programs as you go state to state, but that's how the federal government's role is in that. So that's a little bit different than the Medicare program. In regards to Medicare, the federal government runs that entire program, and it's the same across states, okay? So just to give you a little primer on Medicaid. So every state now has a marketplace. A marketplace is kind of one-stop online shopping for health insurance, okay? So it's a big kind of exchange where all of the health insurance providers kind of meet together. They have all of their information submitted to the state, or if it's a federally run exchange, and then people can go to one place in each state and look and see what all of their options are. It can be overwhelming for some people, but we'll talk a little bit about that, how that works. Also, the plans that are offered through the marketplace are what we call qualified health plans. So what that means is, as the Affordable Care Act legislation was passed, it also was passed with minimum requirements for coverage, all right? So I think you've seen also, I mean, there's been so much in the media, but you've heard some people are actually losing their health insurance, and people were upset about that because they had affordable premiums. But when you actually look at some of those policies, they weren't covering much, or they had huge deductibles. And so what the Affordable Care Act actually does is says, look, if you're going to offer health insurance, you need to cover these minimal services. And this is the minimum standard. And so some people whose policies did not meet that minimum standard actually were going to be kicked off their plans, or some of them actually got letters saying that. We've gone back on that and given people a little more time to stay in their plans with all of the uproar that was around that. But again, that's what the controversy was around that, okay? So the Affordable Care Act is actually trying to improve the quality of people's health insurance. People feel like they have a health insurance, but when they go to use it, they probably can't use it because it doesn't cover everything. So it's a catch-22. But again, if you have questions about that, we can go ahead and talk about that later. So the reason why I wanted to move this presentation up is because the deadline to enroll in health insurance is actually March 31st. So I sneaked in past the deadline because it didn't make sense to give you the information and then not have time to sign up. So March 31st is the deadline to have health insurance. Whether you get it through your employer, whether you receive it through Medicaid, or whether you go through the marketplace and purchase it, you need to have coverage by March 31st in order for it to be effective for 2014, okay? So that means that if you sign up today, then you will be covered beginning May 1st, okay? Any questions about that?
I have a question.
Okay.
What happens if someone loses their coverage in April from their employer plan, if they lose their job or something?
So that's called a qualifying life event. So if you lose your job or something along those lines happen, then what you can do, and let's say you lose your job and you're unemployed, like you didn't go to another job that offers you health insurance, then you can go to the marketplace and sign up. So that's a qualifying life event. It's similar to, you know, if you change your health benefits at work and something, you get married or you have a child or things along those lines.
So there's no date on that?
There's no date on that. It just needs to be a qualifying life event in order for you to go in and sign up.
So is there a grace period as far as, do you know what I mean, or it's almost like if you lose your job like right that day? And
There is a grace period to sign up. It will be based on each state, so you would need to contact the exchange and say, hey, I dropped my insurance, but you have to be proactive with that.
Yeah.
The way it works is there's actually a tax penalty if you're not covered, okay? And I think you all have heard about that as well. So the way that penalty works is it actually goes by the number of days you're not covered, okay? So if you lose your job and you lose your health insurance and you're like, whatever, and you don't do anything about it, then when you do your taxes, it's going to see that you haven't had insurance from whatever day your employer cut you off, right? And so that's your responsibility to be proactive to get signed up for something.
What's the New York number of days?
I have to find that out for you specifically. And the nice thing about New York is that New York actually has decided to run their own exchange. So the federal government doesn't have anything to do with that, which is, well, besides funding it. But they run it completely on their own. They set their own standards, and they also do their own marketing. And so we don't really have a hand in that. But it's actually been great because when we were having all the issues with healthcare.gov, New York was not experiencing that because New York has their own exchange. So kudos to New York.
If you don't sign up, so
By the
you'll be
31st.
found next year when you do your taxes, is when you'll be found.
Yes,
Okay.
for your 2014 taxes. So that's when you submit next year in 2015, by April 5th. Okay? And I can get the number for you on exactly how much it is. I think it's like 1% for every $100 or every $1,000 that you make. It's some calculation on what the fine is. Okay. And some people, you know, are like, hey, I'd rather pay the fine than pay a premium on insurance, and people can do that if they want. So that's really kind of up to individuals what they want and how they want to handle that. So again, the advantages of the marketplace is it does increase competition. So what happens is all the insurance companies are in one place, so they know that people are shopping around. And so it does inherently increase competition. And the premise behind that is that that will improve quality. Again, it increases affordability through enhanced competition, and then it also helps ensure quality of the plans. And then it also makes costs clear, because you can go online, you can see what the costs are for each plan, what different levels the plans are, and you can choose how much coverage you want. Okay? Any questions? So the next slide looks at the marketplace establishment, and I really wish this was in color, because it kind of kills my thunder. But I wanted you all to be able to see there are 16 states that run state-based exchanges. New York is one of those. And then there are 7 states that have state partnerships, so they're working with the federal government to run their exchanges. And then there are 27 federally facilitated marketplaces. New Jersey is one of those. Okay? So can anybody guess why New York is running their own and New Jersey is having the federal government run? Any?
Chrissy?
So the impact of this is that if this was in color, it would show you the different colors, and it kind of reminds us of those political maps that we see at election time. It's almost exactly down party lines in terms of which governors decided to run their own exchanges and which ones chose not to. And so that's a political thing, but either way, everyone has an exchange. It's in every state, and the states that are running their own are actually doing a phenomenal job running them, and the ones that are being run by us in the federal government, I mean, it's happening. The challenge, though, is that the states actually get more money when they run their own exchanges versus having the feds run their exchange. So in New Jersey, we have to do a lot of outreach. We spend a lot of time in New Jersey helping get the word out in regards to signing up for coverage and things along those lines. So it's a little more legwork for us versus having the state health department kind of do these activities. Okay? And just to kind of back step a little bit, to give you an idea of our office is a regional office. We're actually located at Federal Plaza. So Region 2 for the department actually covers New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. We actually have a sub-office. We have about 3 staff people in our Puerto Rico office. So that's our jurisdiction, and that's pretty much the jurisdiction for all of the feds that are in New York City. And so we're responsible for what happens in New Jersey as well as what's going on in New York. So we kind of spend a lot of time in New Jersey. New York keeps reminding us that we're spending a lot of time in New Jersey. We're very territorial with that. Okay, so again, this next slide just gives you an idea of what some of the costs are. And again, this is just an idea of what they look like. You really have to go on to New York State of Health to see what the actual costs are for the individual plans, okay? And it talks a little bit about the tax credit. So what happens when we see these huge premiums and I only make X amount of dollars and I keep hearing about these tax credits, how does that work? And so if you see here, the percent of federal poverty, if you make 100 to 400% of the federal poverty level, and I think for a family of 4, we're at like $24,000 a year, then, and actually it breaks it down here. So if you're an individual and you make between $11,490 and $45,960, then you're eligible for a premium tax credit for your policy. If you make between $23,000 and $94,000 and you're a family of 4, then you're eligible for the credit, okay? If you make between $11,490 and $28,725, then you are eligible for reduced cost sharing, okay? The next one is family of 4, $23,000 to $58,000. So reduced cost sharing means that when you pay co-pays, when you all pay deductibles, are you familiar with this language? Okay, so I don't need to explain what a co-pay is or what a deductible is. You guys we're all professionals. Some of us take insurance, some of us don't. So again, it lowers the cost of your co-pays and your deductibles, okay, based on your income. All right, so that gives you an idea. If you're making over $94,000 and you're a family of 4, then you're not eligible for the tax credits. And so you want to go through, look at the policies, look at what you think your coverage needs to be, and you decide from there what you want to purchase. Are you clear on that? So I'm trying to highlight some of the more controversial things that maybe you've heard in the media. So if I'm talking about something that, it's not that interesting, just give me the signal to keep going. So I talked about the essential health benefits that need to be included in these plans. I just wanted to highlight that number 5, mental health and substance abuse disorder services have now been considered essential services. So this is a big deal for us. Historically, mental health has really not been part of the conversation around insurance and primary care. And actually, in our agency, we're working very closely with SAMHSA. I think you all are familiar with SAMHSA, which is the Substance Abuse Mental Health Services Administration, which is a sister agency of our agency. And their regional administrator actually, well, first of all, this is the first time they've actually had a regional administrator in SAMHSA, which is crazy, right? So they have someone in the field office now, and they actually sit in our office space. So we have the opportunity to work really closely with SAMHSA and have conversations about the integration of behavioral health care into primary health care. And so when we say behavioral, we're including mental health services as well as substance abuse services are lumped into behavioral health care, okay? So this is a huge trend that the federal government is putting money into in terms of the integration, and the Affordable Care Act also recognizes that by saying to all of these health insurance plans, hey, you need to cover the basic mental health substance abuse services. Okay. Questions about that? Okay, so now we start getting into the competition piece. So once we get through the essential services, then individual plans can decide if they want to cover more things to make themselves look more attractive. So they can offer additional benefits, they can see, they can require certain providers to work at certain hospitals, they can set their premiums and their co-pays at different rates to make them competitive. And then again, if you all have looked through your employer, if you've had health insurance, and if they have multiple plans, you have access to see what some of the people who've actually had those plans rate them, because many of them give feedback in terms of what the actual insurees feel about the quality of their care. So they also do that here in the marketplace. So you can see what their little scores are in regards to quality, right? So if they get 4 stars, or if they get 3 stars, or they get 2 stars, you can actually see that through the marketplace site. And then again, coverage varies based on the plan. And then some plans are structured differently. So some are high deductible plans. Some people may feel that I'm okay with a high deductible plan. I tend to be a healthy person. I don't anticipate using a lot of medical services. So unless something really, catastrophic happens to me, I'm comfortable paying a high deductible if I have a lower premium. Okay? Kind of same concept with our cars and with our own health insurance. Okay? Any questions about that? So I'll talk a little bit about Medicaid expansion. I don't think any of us can actually see Medicaid with our license, which is a different conversation that we'll have. But again, for those who are on Medicaid, I think some of you may see Medicaid clients if you work in an OMH clinic. I know I did. I don't know if anyone else has. But it's just important to know that it actually expands the eligibility of people on Medicaid. So before we were at, I think it was 120% poverty, now we're up to 133%. That's basic eligibility for Medicaid across the country. New York is actually up to 138%. New York actually and California have the 2 largest Medicaid programs in the country. No surprise there. But these 2 programs, we kind of go back and forth in terms of who's largest. I think right now California is largest. New York is about $38 billion on Medicaid alone. That's billion with B. So it's a huge program. I think maybe last year you probably saw some of the commercials around the Medicaid redesign that the governor is doing. He's doing that to kind of bring in the cost of the Medicaid program. People, if you ever wonder, people would move out of state, maybe down south somewhere, run into hard times, and then come back to New York. And you're like, why would you come back to a more expensive area if you're having financial trouble? One of the reasons is because the services here in New York are great, We're a very generous, liberal state in terms of taking care of our underserved people. And so, if you're in Georgia and Atlanta somewhere and you fall on hard times, you probably don't qualify for Medicaid in a conservative state because, again, it's state-based and they can decide how much money they want to put into it. So you may come back to New York where you can at least get coverage through Medicaid for your health care, right? So that's one of the reasons why you see that happening. And if you're not a user of Medicaid, then you kind of don't know why people would do that, but it makes sense now, right? When you think about it in those terms. So New York is a very generous state with Medicaid, and having said that, their generosity is getting extremely expensive for them to manage. And all of that impacts us because we pay taxes, right? And those of us who are in New York City, we pay taxes 3 times. And so all of these programs through the state are funded through the tax base. And so this is why the governor is working to address the cost of the Medicaid program and looking at redesigning it, okay? But having said that, the federal government is giving states additional funding to expand their programs. So this means that we'll give you more money if you expand your Medicaid program to cover more people. Did I just confuse everyone?
Can I just make a comment?
Sure.
I think it's fine and great to extend Medicaid, but the problem is the doctors will not allow you to use it. I mean, I called to make an appointment with a neurologist recently and asked, what insurance do you take? And the receptionist said, we accept every insurance except if it's through Obamacare.
If it's through one of the qualified
That's
health plans?
managed.
Okay.
And, I mean, I know people that have seen doctors for years on Medicare, have been thrown off there. They cannot see that doctor anymore.
It's
So
interesting
it's
because
double-edged sword.
we don't know how it's going to look until people are really using it. And we have to look at what, it's the same concept that we have. We choose if we're gonna take insurance or not. And one of the reasons why we choose if we're gonna take insurance or not is based on the reimbursement rate, right? And so these are the conversations that we're having with individual insurance companies. We can't dictate to them, when I say we, I mean the government, we can't dictate what you can pay your providers. We can recommend, but there's no minimum that says you have to reimburse a provider this percentage. We just legally can't do that. And so these individual plans can decide what they want to cover, and then on the opposite end, the providers can decide if they want to participate or not. So again, something like what you're saying is probably very real. People can say, you know what, I don't want to take this particular plan. I'll take this one, but not this one. And that's unfortunately kind of the fact. And it's the same thing with Medicaid. Some people refuse to take Medicaid patients. Sometimes it's because of the reimbursement, sometimes it's not that it's said, but it could be a discriminatory thing in terms of the clients. Right. It's interesting because on one hand we have doctors who won't take them, and then on the other hand we have the issue of what we call Medicaid mills, where people just open up and that's all they see are Medicaid clients, and it really isn't about the care, it's about getting the reimbursement. So there's a lot of places where there needs to be improvement in the healthcare system. And we understand as career feds, we just implement the law regardless of whoever the president is. But we understand that this is not going to fix all the problems with health insurance. It's not going to fix the entire healthcare system because this is not a systemic fix. This is something to get more people covered so that we're not in a situation where people are going to the emergency rooms for primary care, which is actually more expensive model than having the opportunity to have preventive care.
Just kind of, what's the profile of the Obamacare person versus, I think of Medicaid repair, is Medicaid under Obamacare or is it totally separate?
Okay,
And what's the profile of the typical person?
So the Affordable Care Act is actually a legislative legal document, okay? And that's what Obamacare is. So I'm just gonna use ACA, but I mean the Obamacare. So what that covers is the opportunity for Medicaid programs to expand in each state. So like I said before, the federal government matches dollar for dollar what the states put into their Medicaid program. So the legislation allows additional funding to go into that particular program. So that's one piece. The second piece...
But it's still called Medicaid.
It's still Medicaid, absolutely. Absolutely. It's still Medicaid, and it also follows the same Medicaid rules. So there's no deadline on signing up for Medicaid, and I'll kind of cover that. So the March 31st doesn't apply to Medicaid. If you lose your job or you become eligible for Medicaid, it's not a drop dead. You can enroll in Medicaid if you qualify, okay? When we're talking about the Obamacare plans, these are, so let's say you have HIP. I have HIP, health insurance. My group is through the federal government because my job pays for that. But there are also people who have HIP that are on Medicaid, and that's a different group or different line within the Medicaid program. So this will be the same thing. It will be a different line and will be through the marketplace, right? And so we can decide, I can take HIP, but which HIP do you have? And when I call, people ask, well, what HIP do you have? Do you have HIP Prime? Do you have HIP Medicaid? And they can say, well, I'll take HIP Prime, but I don't take HIP Medicaid, or I don't take HIP Prime and I only take HIP Medicaid. So this is what you're saying. If your plan is through that line or that group, then they're saying they don't want to take that particular group, right? And so that's what the difference is. Did I answer?
Sort of.
Yeah. Healthcare is a huge business, guys, and it's very very
pay
confusing.
attention that much to it. So HIP offers Medicaid plans and other plans that other companies might buy for their employees, you're saying. So, the affordable care plans, so if we have, and I've heard people that have their own businesses, who
Yeah.
buy into it and things like that. So that's what I'm asking, so, but it'd still be called Aetna or,
Absolutely,
so
yeah,
Aetna has ACA plans and they
Right.
have plans that large companies buy
Yes.
and they're,
yes. So when we have these conversations about these huge health insurance companies, these are huge, multi-billion-dollar companies, and they have different lines of business, okay? So if we look at HIP, which is the health insurance plan of New York, it's huge, you know, go down to Water Street, see the nice headquarters down there. And so they have different lines. They're not just gonna offer insurance just to private employers. They're gonna offer a plan for private employers. They're gonna have a plan that they offer to the federal government employees. They're gonna have a plan, they have a huge plan. They cover most of the state employees between HIP and GHI, which is all Emblem Health. They kind of consolidated. So if you see people that have GHI or HIP, it's pretty much Emblem Health. It's the same thing. Again, they will cover that separate line. So that's a huge population of state and city employees, federal government employees. They also have a huge Medicaid program, right? So this is the insurance company. And so now with the Affordable Care Act coming in and saying, hey, this is another line opportunity for coverage, right, through the state marketplaces. HIP can say, I want to participate or I don't want to participate, right?
so the only line of business for them.
Will be through the marketplace. So it will be the state marketplace line that people sign up for. And even within that, there's different tiers. So if I decide to go through and purchase HIP, then there's different levels of coverage that I can select within my individual plan, right? So when people call us if we're out of network, you know, we say, call your health insurance, find out if you have out of network coverage for mental health on your plan. I can have one person who has HIP who works for the state and doesn't have it because we didn't select that particular line, and another person who works for the state and does have it, and they can get reimbursed. So it's really about what they decide to purchase through their coverage. And I try to equate it to something that we all use, which is, well, maybe not in New York, but if you have car insurance, right? Or if you have homeowner's insurance, or if you have renter's insurance, you decide how much coverage you want, right? You do the bare minimum, and then if you say, hey, I want a little bit more coverage, I have this really expensive painting in my house that I want to insure also. So I want to make sure I have enough coverage in case something happens to this house, or to this entity. Or, you know what, I have a chronic illness, I have diabetes. I need to go to the doctor every other week. You know, so I'm probably going to pay more for my coverage so that each time I'm not coming out $50, $60 a copay. You know, those are personal decisions that you make once you're in the system signing up. And so if it helps to give you an idea, before that was the gap. The gap was if I don't work for a company that has health insurance, or if I don't qualify for Medicaid, then where do I get insurance if I want it? So then I'm going to some of these private companies that maybe I see on TV or, you know, that I've heard about. And these were some of these policies where people were getting dropped off because they signed up and it sounds great, you know, you're only paying $250 a month for your coverage, but then when you try to use it, there was really no regulation in terms of what they're supposed to cover. And so you find out that, okay, well, I can't use this because it doesn't kick in until, you know, I'm like half 1 foot in the grave. That's when the insurance kicks in. You know, or it doesn't cover these basic primary care, preventive type services, right? So that's kind of how it works.
But I think it's also important to remember that the private insurance market, the reason why we watch so many stories and people are talking about around the country losing their insurance, but the private insurance market in New York since the 90s has been, from my understanding, especially because of California, is very different here than in other states. You know, for example, in California, prior to the Affordable Care Act, you know, as a young healthy person, I could get a PPO individual self-employed plan for, you know, $180 a month or something. When I moved to California, or when I moved to New York, no such plan existed. And the cheapest plan equivalent is like $700 a month. So I think that that's why, you know, New York, I think, is different than a lot of other states and some of the reforms that I understand were put in by the Cuomo administration having to do with denial of coverage and some of these things that the Obamacare or the Affordable Care Act are enforcing across the country that were already in place. Some of these things
In different
New York.
states.
Yeah, in different states.
And so it's really trying to set a standard. But the government doesn't run, the federal government doesn't run states, right? So if a federal legislation comes through and says you're supposed to do this, it's not saying that we can now dictate how you implement. Does that make sense? So we go through and make sure that you're hitting the line, but we're not gonna say you have to do it this way or you have to do it that way. You just have to meet the standard. And so you are gonna see some deviation state by state. And so that's why I was kind of asking where everyone was living, so that we can really specifically talk about what's happening in New York, because it will be different in New Jersey and it will be different in some other states. We know that Massachusetts has had, universal health care for the state of Massachusetts for years, right? And this was kind of one of the conversations that were had when this legislation was being written. So they've done that in their state. So everything is different. And even with insurance on other types of insurance, all of this is regulated at the state level. So if you have some type of insurance with your car, with your house in one state, it'll look different in another state when you move. So that's kind of the concept here. But again, I think the point is there's an attempt to make some type of regularity and also for people to increase access to health insurance, but not only access, but quality access to quality plans, right? So that I'm not paying $250 for something that I can't use anyway. Any other questions?
I just had a comment because I'm a social worker, so I'm also on most of the insurance panels, and it gets a bit complicated with the different lines because I could be an Aetna provider, but I am not an Aetna Medicaid provider. So people will call me, they have the Medicaid line, and I can't see them, but they've gotten my name through Aetna. So you have to sort of be so cautious to check.
It's very confusing.
It's very confusing.
And this is how the insurance companies are running. That's a whole different conversation getting into that business. But it is a business, and we have to understand that healthcare is a business. And so, it's something that impacts us physically and mentally, but we also have to see that these insurances are running businesses and they're for profit.
So you were saying that HIT and GHI were under Emblem?
Yeah.
And how is Emblem connected to Blue Cross Blue Shield? Because quite often I find that the Emblem plans are Blue Cross Blue Shield plans, which doesn't recognize.
Empire is, I don't think Emblem is part of Blue Cross Blue Shield. Not that I'm aware of.
I don't think it is.
I think the Empire plans are Blue Cross, Empire Blue
So
Cross
if
Blue
you
Shield.
have just an MFT license, you can take GHI?
DHI does not cover it.
Well-
They're like one of the worst ones for us.
But I've had some city employees just aside, have great coverage. They have great out-of-network coverage. And I've had GHI, city employees, as a city, and I've had GHI clients be reimbursed for me out-of-network. But again, that could be based on their plan. And I really don't get into that with clients. Like, I just have to call the number on the back of your card, ask them these questions. We all have the standard 3 questions. Do I have out-of-network coverage? What are my deductibles? Do you cover a licensed marriage and family therapist? Those are the 3 questions that they ask. And then I kind of let them go through that process. So I don't even ask, I know if they're city employees because of the intake form that they fill out. So I can have an idea of where they work if they have jobs. But I usually don't ask, what line are you in? Just call the insurance company and find out. And part of that is because I don't want to do it, I don't have time to do it. But the other part of it is that we really need to take responsibility for understanding our own coverage. A lot of people buy these plans and then they get upset because, well, it doesn't cover anything. When you signed up, did you look to see what it covers? Do you have an idea of how you use healthcare? And a lot of people don't. A lot of people just have no idea. They don't have regular visits to their doctor. They don't even know who their doctor is. Maybe they didn't pick their own primary care provider. You would be surprised how many people don't really pay attention to this. And so when they come to us because they're having an issue, they don't know what their policies cover. And so part of that, having them call, gives them the opportunity to actually engage with something that they are paying for. Now, they'll get upset when they find out that they don't have the coverage, but I also try to use that as an opportunity to educate people just because I work in public health. You know what? The next time you can sign up, make sure you look and see what the mental health coverage is, if this is something that you want to bill for, or get reimbursed for. So in order for us to have those conversations with our clients, we also need to know kind of how things work. Even if we don't take the insurance directly, they have it, they want to use it, and that conversation is a difficult conversation. We don't want them upset with us, but we also, as part of the therapeutic process, is for them to take responsibility for what it is that's going on with them, right?
Yeah, I just add another distinction, a lot of times, someone's medical and mental health are not
Absolutely.
at the same company, so you have to make sure you're asking them to verify their mental health.
And usually there's two numbers on the back of the card. Usually there's a separate number for the mental health piece. And so you may want to tell them to also, if there's another number, call the mental health. And I always tell them, you know, if you have out of network, yeah, I go to any doctor. I always say your mental health coverage is different than your medical coverage. So you want to find out about the mental health piece.
Is that likely to change with the way the
Well, you know,
restructuring is going?
not necessarily, because they can, like with HIP, I think they contract out the mental health services somehow. And so my copays are completely different on the mental health side than they are on the medical side. And that's okay, they can do that, as long as they're covering the basic services. And so then it's up to me to decide which plan I pick, how much I want to pay out of pocket based on coverage.
Or how does the parity law fit into that? Does it just say that you have to provide coverage? Because I mean, the concept of the parity law is that it's supposed to provide coverage to be equivalent for medical.
Right. Yeah, it is, and so what we're talking about is you can't say you can pay, your copay has to be $100 for your mental health services, but your copay is $20 for primary care. It needs to be on the same level, but it doesn't necessarily have to be the same, okay? And what she's talking about is, in addition, before the Affordable Care Act was passed, the mental health parity law was passed, so that insurance companies could not unfairly basically overcharge for the mental health side and charge higher for mental health services versus what they were charging for primary care and medical services.
Or put limits on the amount of visits, is that?
All of that is the same concept. Because what was happening, and I think you might have noticed it, I noticed it in my own, where I used to have a limit on the number of sessions. Now I don't have a limit at all on the number of sessions, but my copay went up a little bit because of that, I think.
I had a woman tell me she had 20 visits, a limit, this past week, so.
Okay, but does she also have a limit on the other, what insurance does she have?
I can't remember anything.
So again, you know, when you hear things that kind of sound a little bit,
Oxford, she has Oxford, United Healthcare.
United Healthcare?
Yeah, United Healthcare, Oxford.
Okay. So again, you know, there, and I don't know because I don't know what her entire policy looks like,
Right.
but when we're talking about this, you may want to ask, you know, what's going on in other parts of your policy. And if you feel that something unfair is happening, at least on the mental health side, or doesn't make sense to you, you may just encourage them, hey, call your insurance company and find out, because it really shouldn't be this much of a disparity between what's covered here and what's going on with your medical side.
Let me tell you one other thing I encountered last week. A man I've been seeing, he also has the United Healthcare Oxford plan. He used to pay $50 for his copay, and the total reimbursement from United Healthcare is $60 for a therapist.
Okay,
So they would send me $10, okay?
that was nice.
And now they're not sending me anything, and he has to pay the full 60. Yet it says on his plan that he has mental health coverage. But in reality, he's paying out of pocket.
So his copay is 60,
It's now 60.
and the reimbursement rate is still 60 for you?
That to me sounds very illegal, I don't know.
Well, it's not illegal.
It's not.
They can raise his copay. So the question then becomes, do you want to continue to take that insurance, right? And that's the other question. Do we want to participate in these plans? And it's, you know, we're just a small microcosm of the system, and so we're running into that. Some doctors are not going to take it, you know. And we can't force doctors to take it. You know, we can't. It's, you know, we can't. And so people have the prerogative, and you know, some people take insurance because it makes sense for their practices. Some people, you know, can just pull people off the street because they're just so well known that they don't have to, you know. And a lot of people in Manhattan can do that. They can practice. I don't know if I could really run a practice in some other places or different parts of the country with people paying out of pocket and even doing a reimbursement thing. I mean, that's also based on the economics and the socio-economic demographics of where you're practicing. And so we'll probably see a lot more of that here in New York City because providers can kind of do that. But they've kind of always done that too. Most of the ones that are going to continue to do that have always done that.
It just goes to show intro that you really have to know all the ins and outs. And it's just so intimidating because it is so convoluted. I mean, just on the professional side, but then for the client side, they're just, oh, I have this insurance, and
Here's my card.
yeah, they don't know all these different lines and ins and outs. And then we're supposed to know all, and like we are a healthcare, not just provider, but an insurance company.
Right. Well, we're definitely not insurance companies, and we have to be clear that we're not. Because you don't want to get into that conversation with someone, because 9 times out of 10, you're not going to end up being their client anyway. Not to say it's not important, but that's kind of the reality. So what you want to have is enough where you can lead people in the right direction in terms of how to get more information on this. And we'll talk a little bit about, there also has been funding that has gone into actually hiring people to help people go through this process so that they're not just sitting at computers looking at hundreds of plans. And in some states, in New York, it's a lot of plans that you have to look at and cross-reference. And some people, they can't do it. Like, it's information overload. And then that's for us. And then we look at the elderly or people with disabilities or, language barriers. I mean, it's a lot to deal with. And so we do have people that can assist with that. And the federal government has funded agencies to actually provide that support service for people as they're signing up. Did you have that?
Well, it was just, she would have to know that if somebody called and said, do you take this insurance? Well, what line is that? Oh, this is my hourly rate, your insurance only covers this, so I decided not to do it. I mean, you just have to, do you get into that
No,
conversation?
absolutely not.
Or, I mean,
No. You don't.
so you just have to say I don't, or do or don't take.
Well, if somebody calls and says, do you take Aetna? And you know that you take Aetna, I know that there's some type of process that you do before you take the client. So you'll call and make sure that they're covered. And so if you find out that they're Medicaid, you know what, based on your group, I don't take that group of Aetna. That's what I would say. I wouldn't get into too much of that conversation because there's really nothing that you can do once they've signed up for their policy. The only thing that you can do is encourage them when they're signing up or they have the opportunity to change to pay attention to their coverage. That's all you can say to people. Because once they've signed up, they've signed up. You can't get rid of the policy. But once the year ends and they're eligible for a new policy, then hopefully they'll pay attention. Sometimes we don't know that we want to see a therapist in that particular year. So maybe we didn't sign up for it. But then the next year when we're able to sign up for our insurance, we'll say, you know what? I think I'm going to start seeing a therapist on a regular basis. Maybe I need to look at what the mental health coverage is. It's the same thing if you had a major diagnosis, right? And you know that you were going to start using your insurance more. Then the next time you can sign up, you're going to look at that policy differently. And that's what I would encourage people to do. But I really wouldn't get into how you run your business and why you choose lines and all that. Like, I really wouldn't get into that with clients. It's too much information.
Just a question on the rates that they pay. So I know we've lobbied in Albany with the legislators, usually their assistant or something, sitting needs to or something. Are they looking at the $60, which seems to be the general rate? It seems like for Medicaid, they pay more, correct?
I don't know what Medicaid.
I've heard from, I think they
don't
pay
cover
more, when I talk to the agencies that I work with. Do you think that's true? And I've heard it's
I don't know
more.
about New York, I just know in Texas it's less.
Okay, I believe it's quite a bit more, is what I've heard from agencies.
It depends on your state.
I see.
So I'm just wondering, where is this $60 value number, I'm coming from, what could we do? Because,
Well,
I want, that's just.
So here's the thing. Insurance companies are regulated on the state level. So we have no say on what we can't do. This country would explode if we started telling insurance companies or any type of business what you can charge. I mean, this is a capitalistic society. They can charge whatever they want. They can reimburse whatever they want. So we don't have any say in that. Now, in terms of what the state can do, the state has a lot more power in terms of how they regulate their insurance companies. Those are state insurance commissioners that regulate these things. And so that's why you're lobbying at a state level. And that's why you'll see variations state by state based on what the state chooses to do. And so the federal government, we really can't do anything about that. But at the state level, yes, you can advocate, you can talk to your legislators, and they can influence in terms of what the state is requiring of different insurance companies. And it's not just with healthcare. Healthcare is a major piece of it, but it's also different lines of insurance that are regulated.
Yeah,
they don't take Obamacare, right, so
Yeah.
something's wrong.
Yeah, I mean, at this point, I don't think any legislation on a national level would pass if we were to say, you know what, you have to take this line. Like every provider has to take
Right.
clients who are insured through
And just how
Marketplace.
do they get this number and what can we do, you know?
You mean, are you talking about the actual rate they reimbursed us?
Yes.
But that's the business decision of the insurance company.
And we haven't had a rate increase, as far as I know, since 1998, or even before. It's been $60 since then. No raise for how many years? What other occupation has that?
You know,
As far as I know, there's a way to have a dialogue though with those insurance companies and make your case essentially for, I haven't been able to do it yet, but
I don't know anybody who's.
with Aetna, I just recently got, what they need from me in order to kind of make my case. So I'll let you know how it goes. But, you know, as you can make your case with how, you know, certifications you've gotten, how much experience you've had, if you've received any other degrees in that period of time and things like that. I mean, I think you can go to bat for yourself
Well, I
directly.
know from being in Texas, the rates were the same. And they told me that it was based on zip code, that the rates were.
Right,
So when I came to New York and thinking, oh, I'm gonna make
Yeah.
more money, you know, that's
yeah.
yeah, but yeah, it's definitely different state by state.
yeah.
And it's also different plan by plan. So some plans can choose to increase their rates and some can choose not to. And so it really is a business decision. And I think it's important as providers that we understand where the state and the Fed's responsibility ends and when you're dealing with another business. And the insurance companies are businesses, but so are you. So you can decide if you want to participate, if it makes sense or not. A lot of the insurance companies feel like, hey, I'm like, you know, I'm providing you with all of these potential clients. So that's why, you know, that's the advantage of being in network with me. You know, you have access to all of my insurance bases, you know. And so that's kind of how they justify their insurance rates or their reduced rates from what you're paying. And for some people, based on their practice model, they agree with that, you know, and I'll take the insurance because I know that I will have clients. Some people say, you know what, I'd rather put in more work and find self-payers out there in the universe somewhere. And so that's a business decision that we make on our own as providers. And the struggle really has been that it's been difficult for mental health providers to kind of get a living wage working with insurance companies, and doctors have kind of advocated for themselves to the point where they can. And that's where some of the parity laws have come in to kind of help with that. But again, you know, this legislation does not change the entire system. The system is the system. It really increases people's access to the system. It increases people's ability to have quality care and that they're not having these junk policies. And then it covers more people for Medicaid, so it increases the base there. The state is already investing a lot of money, but if you're a single man with no kids, there's like nothing out there for you, right? So if you're not married to the mother of your children, but you lost your job, you will never qualify for Medicaid. Now with the expansion, there's an opportunity for that to happen. So that's really just increasing the coverage area, but it's not necessarily changing the entire system.
I was just gonna say, the zip code thing is interesting because if a doctor has an office, say in a nice part of Manhattan, you may get a rate that's high there. You might have another office in a not nice part of Manhattan, a lower rate, same person, same service. Because the insurance company calls it what the market will bear. So like they're comparing it to other local.
Absolutely, and then you know, at least I take TRICARE, that's the only thing I take. But with TRICARE, it always asks where was the service location, you know, and where was your office located, so everything is zip code based. And so they're gonna reimburse you based on where it actually happens.
Well, why would Westchester be as low as San Antonio, Texas? It shouldn't be.
So let's go in the interest of time, because I don't want to keep you all here. We're not having a board meeting today, so I don't talk all day, I don't want to do that to you. The next map you can see a little bit better in the black and white, but again, it's showing you, you know, how the country looks, and it looks just like a lot of our political maps in terms of who's expanding Medicaid and who isn't. So I'm actually on slide 11, I don't know if the slides are numbered. But that's just a visual of which states decided to expand their Medicaid program and which states decided not to move forward at this time. And the darker color are the states that have chosen to not move forward with expanding their Medicaid programs. Does this look interesting to you all at all? It's right down the middle of the country, right down in the southern tier, right? And then a little bit of New England. So it's very important for you all to understand how politics impact policies, right? Are you all following? So it's important, I mean, when you see maps like this, and I'm not, I'm apolitical here, but it's important for you to understand how the process works and how you advocate for whatever it is that your vested interest is, right? And your leadership in your states. So the federal government offers this opportunity. You can see the states that say, hey, we want no parts of this. And they, we can't say you have to, right? And so a lot of that is based on the leadership and what they've decided to do in individual states. And it also shows what it may look like if you decide to move to another state and practice there. You can kind of see how some of those things may impact on your practice.
Because we don't have
You don't
that.
have
It's just hold it up so that
It's
you
all
can
the
get
same
it.
color?
Yeah, it's all the same
It's
color.
like killing my thunder, guys. Expanding Medicaid
Yeah,
at the time, so it's just all
yeah,
one.
no, it's just, yeah,
Okay, so can you all see this?
at least generally the same, yeah.
So the dark color are the states that chose not to expand. Looks like election. Let it work. Okay, and then again, just really quickly, I'm gonna go through this quickly in the interest of time. The next one is the eligibility cheat sheet. So this actually kind of shows you where people fall. And this is who would qualify for Medicaid. So basically, anywhere between 0 and 138% of poverty, you would qualify for Medicaid, okay? You would also qualify to purchase your insurance through the marketplace, okay? And then there's the only exception here are legal immigrants on this piece in terms of the premium tax credits. That's the last column, okay? Between 138 to 250% of federal poverty level, generally you won't qualify for Medicaid, but there are some states out there that may have a generous policy that may cover that range of income. And of course, you can qualify to purchase through the marketplace, and you may qualify for tax credits or reduced cost sharing, okay? Anywhere between 250% to 400% of poverty, you're not going to qualify for Medicaid, okay? But you can purchase your insurance through the marketplace and potentially qualify for premium tax credits. So that's kind of how this works. And again, the federal poverty level for a family of 4 currently is $24,000. So that's considered poverty. Next one is in terms of, starting in 2014, everyone has to have the minimum essential coverage. So this is by this March 31st. Or you need to have an exemption, okay? And an exemption really is, from what I'm understanding at this point, an exemption really is if you are a tribal organization. So if you're a federally recognized tribe, you're exempt from this. And then also, some religions are exempt from this. They have a religious exemption. I don't know what they are offhand, but those are pretty much the only 2 exemptions. So if you're a member of a federally recognized tribe, you're exempt from this. And if you are a member of a particular religious organization, you're exempt, but I don't know what that is. Okay.
Is that because they're not going to use health coverage?
What, the tribes?
The tribes or the religious?
Well, there could be some religious justification for not pursuing healthcare or whatever. And actually, I don't.
Jehovah's Witnesses,
Right.
certain.
Right.
Scientology.
Okay. I have to actually look that up because I don't know which ones are actually exempt on the religious side. I know that the tribes are exempt, the federally recognized tribes are. And that's a whole different conversation with the tribes, and I'm sure you guys can understand why. But they do get their health service, their health care through the Indian Health Service, which is a separate federal agency that runs health centers on tribal reservations. Okay, so they do get funding through the Indian Health Service to run their health care. So that's why they are exempt from this piece. And they have a strong disdain for the federal government. I mean, we're doing a lot of work trying to engage tribes, but they're just inherently mistrustful of us, and we understand why.
Yeah.
So who will, yeah.
Is there a later deadline in certain cases? I heard like if you're covered right now under COBRA, that you have a later deadline, it's in June or in the summer or something like that?
In terms of
To sign up, March 31st deadline is extended, I heard, for,
The COBRA is considered covered.
you have to sign up if you wanted to get coverage, if you wanted to sign up for,
The COBRA?
Wouldn't that just be under the?
on the
COBRA,
marketplace.
Yeah.
And you would lose your
Yeah.
coverage, because you're eligible for coverage for a certain period of time after you lose your job.
Right. Yeah, it would be a qualifying life-changing event if you were to lose the COBRA coverage, or if you wanted to come off COBRA and go into the health plan.
So that can
The
happen at any point.
marketplace.
Yeah,
Yeah, I'm not sure. I have
Oh,
to find
okay.
out about that.
okay,
Because I haven't heard of any other deadlines besides March 31st.
that's the only one. Okay,
Right, and then the qualifying life events.
okay.
And then with Medicaid, there's really no deadline. So once you qualify for Medicaid, you can sign up at any time of the year something happens. Okay, and you can apply at any time of the year. So let's say March 31st passes and you never signed up for insurance, but then you find out that, hey, I qualify for Medicaid, you can still sign up for Medicaid at any time. Okay. So who will remain uninsured? Citizens under 100% federal poverty levels in states that don't expand Medicaid will remain uninsured. Individuals who are not lawfully present. Persons who are exempt from the individual responsibility payment, and again, that's the tribal organization or religious objections. And then people who choose to pay the individual responsibility payment, so that's basically a fine. It's a nice way to say it. Okay, so those are the people that are going to remain uninsured.
Well, not lawfully present means illegally.
Yes. That means undocumented. And so, that was a huge controversy, if you all remember, as part of this legislation passing. And it's always been controversial, even with the Medicaid programs, right? And some of our other health insured, federally qualified health centers that we run through my agency. Since I'm taping this, I'm not going to say what I want to say. But we don't ask people's legal status when they come to our community health center. We don't ask that. We ask for their financial documentation to find out what they can pay, what the minimum fee is going to be. They're all on sliding fee scales, but we don't ask those questions. Now the question has been raised, through all these different federal agencies that are going to be checking to see if people are insured, how that's going to work. And I really don't know how that's going to work because, you're going to have the IRS looking at this because this is a tax issue now. You're going to have different agencies kind of looking into this. So people are concerned. Undocumented people are concerned about how this may impact on them. But in terms of our community health centers, we don't ask their status. But we do ask for them to provide this documentation on their income. Okay. And I'll move on. So again, how the marketplace works. So let's talk about that really quickly. You go online and you create an account. The second sheet that I gave you all was, I gave you two sheets. One was just telling you about New York State's marketplace. So this is specific to New York. So when you all see all of these healthcare.gov horror stories, it doesn't apply to New York. So when healthcare.gov was having those embarrassing website issues, it wasn't impacting on New York's enrollment at all because New York runs their own, okay? And that's called New York State of Health. And it's actually newyorkstateofhealth.ny.gov, I think is the website. So you'll go there and you'll create an account. Then you'll apply, and then you'll pick your plan, and then you're enrolled. That's easy, right? No problem. That should take 5 minutes. And of course we know that doesn't take 5 minutes. But you really need to kind of sit down, devote some time to looking at the plans and shopping, right? And you don't just go into the store and just buy the first thing that you see. You want to go through, see what they're covering. There's different tiers of services in terms of, I think it's platinum, gold, silver, bronze level, right? And rule of thumb is the higher the level, the less your copay is. So the less your premium, let me get it right. The higher the premium level, so like if we're at platinum, then we're probably paying more upfront and less on the back end in terms of copay, and then so on and so forth. Right? So we're paying more in, but paying less when it comes to actual face-to-face providers. So those plans are basically more expensive. Okay? And depending on what your financial situation is, that could work for you, depending on how you're going to utilize your health services. Again, like I said, if you have any kind of chronic conditions where you need to see a doctor on a regular basis, you know, you may wanna pay more upfront so that you're not coming out every time you visit a doctor. If you're gonna go to the doctor once a year for your annual checkup, or if something happens and you know, I don't know, break your foot or something like that, then maybe you're more comfortable paying a smaller premium, and then if something happens, paying a larger copay when you have to see the doctor. So in terms of times for enrollment, again, we have the dates that are here, and these are the only dates that I have, Dana, so I don't know if about this other June date, but I can check. But again, for people that are signing up between today and the 31st, your coverage will be effective on May 1st. April 1st coverage, you had to sign up by March 15th, which I think was last Friday or last Saturday. And so the way that you can get coverage, if you don't want to do the whole online thing, you can actually give them a call. There's an 800 number. And New York is pretty awesome in terms of how they're running their exchange. I think their numbers, there are over 600,000 people that are actually enrolled in New York State through the marketplace, which is a huge number. You can do this over the phone. They have people, customer service, people that are available in multi-languages to actually talk you through the process. When you call, more than likely, you're still going to do it online, but you can talk with somebody as you're doing it online. They accept paper applications, but they're really discouraging people from doing paper applications because paper takes longer. So if you do a paper application, and even if they're talking to you over the phone with the paper, they still have to submit it, scan it in, and do all these other things versus getting an immediate answer in terms of if you qualify for any of these tax credits or things like that if you do it electronically. So if you call, they may still have you, either they'll assist you and do it on their side electronically, or they'll talk you through it on your own computer. And of course, if you don't have a computer, you can go to the public libraries, various places where you can access the computers, okay? Also, again, online, in-person help, so there are certain locations, and you can find this on New York State of Health. This side that's on here is the healthcare.gov number that you use the New York number. And there are actually agencies that have been funded by the government to actually sit down with you and go through this process. Most of them are, again, doing them on kiosks so that we're not doing paper applications because it just takes too long at this point. But there are places that people can go in person. And then, of course, you can do the paper application. And again, this is something that you would want to share with people that are asking you. So whether it's your clients, whether it's people that you know that don't have insurance, you can show them how they can access it. If they live in New York, they can go to New York State of Health. If they live in New Jersey, they need to go to healthcare.gov. And all this is based on where you live, not where you work. Okay, so that's the other thing. If you live in New Jersey but you work in New York, then you have to go to the New Jersey exchange.
I was going to add, my own personal experience with that was, even though I waited 45 minutes to talk to somebody, they actually did go through it with me and were very helpful and very knowledgeable.
Oh, good. So you did it over the phone or you did it in person?
I did it on the internet and I came across some issues, and the problem with the internet was it's so simple that you don't know what you did wrong.
Okay.
And so it just tells you, we don't have enough information. It doesn't tell you what information we don't have.
Right.
So then I had to call and say, what's the problem here? I had to wait 45 minutes. But they were able to say, I think it's this, submit this for us, or some extra or whatever. And then I just got a letter in the mail. They didn't tell me how long it was going to take.
Okay.
They probably didn't know.
Yeah.
But it didn't take, it was like within a week, and it was boom, and then I got my card, and I'm good.
That's good to
Yeah, it
know.
was really, I mean, there's some glitches, but it was overall.
So to give you an idea of how it's working in New York, the agency that actually is overseeing all of this enrollment is the Center for Medicaid and Medicaid Services, which is a different HHS department. And so they're overseeing all of these activities, but all of the agencies are participating in the outreach and enrollment and making sure that people know what's going on. And so New York will report to CMS on their activities, difficulties that they're having, and they are really working very hard as things happen to kind of respond and make adjustments in their system. So it's good to hear that even though you waited 45 minutes on the phone, that they were able to address your concern because they're actually tweaking the system as they go along. And I think, there's really no excuse for why healthcare.gov was the travesty that it was, but that's government contracted, I guess. But when you're at the state level, you can just respond so much faster than anything that we can do at the federal level. And so for the states that are actually running their own exchanges, I feel like their people are just having a much better experience with this. And, at some point, it's really not about politics. It's about what people are able to access, right? And so, New Jersey is doing well. Their numbers are nowhere near what's happening in New York, obviously, but the word is getting out and people are really starting to sign up and get coverage. New Jersey, geographically, is a small state, but it's very densely populated. You guys live in New Jersey, right? And so, we're really concerned about getting people enrolled and covered in New Jersey as well. Okay? So again, this is just more information. You all can take this with you in terms of the certified assisters. These are the people that can help you. It talks a little bit about what you all can do as providers, and we've already talked about this, letting people know what their options are, explaining to them how insurance works, and really this is about your comfort level. You don't have to go too detailed into insurance if you don't know it, but we have kind of covered the basics in terms of people taking responsibility for their own policies. And again, if people don't want to, they can pay, what do we call that? I gotta go back and find out what that word was, but we can pay.
Personal responsibility.
Thank you.
Fee, I think.
Personal responsibility payment, right, if they choose not to enroll. And then again, that's really where it ends, so don't feel like you all have to become insurance agents if somebody asks you a question. Again, now with New York, just leave them to New York State of Health, and those people are there to answer specific questions. Okay? And I think that's it. Any questions? I think we kind of talked as we went through, but any last minute comments in terms of how you think this is going to impact on us and our practices? And maybe the ones who actually take insurance may have a stronger opinion on this.
I've actually seen more private pay people in the past 2 months than I have. I don't know what that means.
I think that we're not going to know until this first year kind of happens. Once we pass this deadline, we hear all kinds of stories. I think I've even heard, well, now that Obamacare is out, they're no longer going to do out-of-network. I don't believe that. I think out-of-network is still going to be there. But, I don't know. I don't have a crystal ball. We're going to have to kind of see how this all plays out. I think that for 2015, there's going to be a lot of changes and tweaks probably in the plans themselves, as well as the exchanges. But again, we don't know. This is brand new, so we'll have to see how it goes. But one thing we do know is that people are covered who choose to be covered, and the plans that they are signing up for are plans that cover the things that they're going to need, the basic essential services. So that's some accomplishment, and we'll kind of see how things are actually implemented as we go through 2014.
I think the big question is the out-of-network coverage. What have you seen so far in the plans in terms of, under this plan, how they cover out-of-network compared to private insurance typical plans that you see?
My practice is small, so the majority of people that I see, for the most part, they are employed. So they're under their insurer's policies. So and for some reason, I just have a lot of city employees, and their coverages haven't changed.
We have out-of-network for people, but in terms of what you've seen, in terms of what's in the marketplace and what they're offering for mental health, have you seen what they're offering in terms of out-of-network? I guess that's the big question, because there'll be more people probably insured by this that might have been out of network or pay out of pocket people before. Potentially, that's what I'm thinking.
Yeah.
And so they might, if they get this and then the out-of-network coverage is not there, there's a concern that there may be more pressure or something.
Absolutely.
Like that's what
Yeah, for that particular line,
Right.
But I don't know, because I personally haven't seen anyone or been contacted by anyone who has insurance through the marketplace and who has attempted to do out-of-network.
And you don't see it through through the marketplace, what
No.
they're offering, you can't see the different plans that they're offering.
Oh, I can see the plans, but I don't have time to go through all of them.
Okay, you haven't
Yeah.
seen what they're.
No, and I think, again, we're not gonna really know anecdotally until people start really using their plans. So we're still really enrolling people, and we're only in, what are we in, March? So we're only 3 months into the year. And I think as now everyone is getting settled, May 1, everyone and whoever is in the plans or will be in the plans, we'll start hearing the stories coming out from the field, I'm sure, pretty soon.
But do we have access to see what these plans, if we're not signing up for them, we don't have access to see what they cover for everybody?
Well, you can go on, you can go through the whole process, you just don't have to sign up. So if you want to shop
And then
and
you can
look,
see what the different plans are
Yeah.
for out-of-network.
yeah.
you want to talk about what networks you're in and how they work for you?
Oh, in terms of insurance, what insurance I take? I only take TRICARE. Yeah, I only
And
take.
you're LMFT?
I'm an LMT. I take TRICARE because I'm an Army brat, and so I feel like I have to give back to the military. But that's the only insurance that I've taken, and everything else I'm out of network for. It's interesting with Inland Health, when you're out of network with Inland Health, they want all your stuff anyway. So they want your license, they want your insurance coverage, your malpractice, all of this stuff. And so once they kind of set you up, they have like this separate out of network like group. Then people can just call and give them their number. So whenever I see someone with PIP or GHI, I say, just tell them my name, just give them my name. They'll let you know immediately if they cover me or not, because they have all of my information, which is convenient because they'll get a no or a yes really quickly, but I'm not in network with them. You know, I was like, why am I sending you all this stuff if I'm not in network? But then I realized that when people go for the out of network, they already have it, so it's seamless for them to get the reimbursement. I don't have to keep submitting all of this stuff to the companies. Emblem Health is the only one that I've done that with. I haven't inquired with the other ones, but TRICARE is the only one that I personally am in network with.
I'm sorry, I'm not clear, was that something you did with them or they did with you?
Well, I called them because I was curious to see if they would tell me what their rate was. And they didn't. And so, but then she let me know, if you want, you can send us your information, you can keep it all on file and just update it. And I sent them my license, my malpractice, all of this other information, and they just kept it. And so everyone who's had those two insurances who go for out of network, I've never had to, nobody's asked me for anything else from those companies. And they're able to just give them my name and they can say yes or no, because then they see that I'm an LMFT and they don't have to go through all of that.
So you've got yourself in the system, basically.
Right.
I was just gonna say, from looking at the, I didn't end up signing up for one of these plans, actually, I have freelancers insurance, which is another option for self-employed people, or, we can ask me about if you want, but I didn't see that any of the affordable care plans on the, or any of the out-of-network benefits for anything. They were all in-networks, all the ones that.
They were all in network only?
Yeah. That was my experience.
Has anyone else tried to
Part of the
sign up
reason I
for
didn't
the
get it.
marketplace? And I didn't really cover the small business portal. The small business portal doesn't close on the 31st. So for businesses, that's pretty open. So if you hire employees or you have a fair number of employees, you can still look at plans to cover your employees through the small business portal. That the March 31st date is just for the individuals. Dana, do you know?
I realize a lot of what people wanted to know today was how's it gonna affect us as therapists, right? And a lot of it's speculation, like you said, we're gonna have to just kind of see how it shakes out and see what people choose to do. So there was that one article in Psychology Today where, you know, the guy was kind of putting his opinions out there and he was saying, what is it called? Accountable care organizations. I don't know if you can speak on that a little bit, but his prediction was that it will most likely go more towards that there'll be these medical centers for therapy. Is that what that?
Yeah, but if you read that article, and he was really talking more about psychologists and psychiatrists coming into these accountable care organizations.
Okay.
And these are just reimbursement organizations that are recognized by the Center for Medicaid and Medicaid Services. And it's really they're incentive-based to encourage people and providers to come together to provide more efficient care. And the thought process is if we come together and we have certain standards that you meet, there are certain quality standards that they meet, where they'll get a higher reimbursement rate if they meet those quality standards. Okay.
Set by
CMS, which is the Center for Medicaid and Medicaid Services, it's a federal agency.
So that would apply to us anyway.
No, because we're small private practices, but he's talking about in that particular article that you're referencing, he's really speaking to psychologists and psychiatrists and how they're going to practice.
And why not MFT?
Well, he wasn't speaking around CSWs, MFTs. He was talking more around, psychiatrists practice completely different than we practice. I mean, they prescribe medication. They see a higher volume of clients for less time. Our practice models are just different. Psychologists tend to they do psychotherapy, but they also do a lot of evaluation and testing. So those practices are just different than what we do in terms of being the providers of direct mental health care services. And so this particular article that Dana is referencing was about how they would start practicing a little bit differently to get reimbursement for those type of activities that they do.
Yeah, I'm not sure if this is related, but we had a meeting at Mercy College with one of the agencies that we work with in the Bronx, and they were saying that they're getting pressured to do be part of these integrated clinics that are medical and mental health together.
Mm-hmm.
And is this the same thing that we're talking about?
No, that's not what we're talking about with the
Because
care
that's
organizations,
Medicaid,
but
yeah.
what that is what I was mentioning before, that we've been working to integrate primary care and behavioral health care.
Right.
So if any of you, in the interest of time, we've got about 5 more minutes. If any of you know how New York is structured, I always like to say New York is like the most backwards progressive state in the country. One of the reasons I say that is because it took us forever to get licensed as MFTs, right? 2006 is ridiculous. So that's my soapbox there. The other side is that New York actually has 3 health commissioners. We have a health commissioner, we have an office of mental health, we have a mental health commissioner, and then we have a substance abuse commissioner. How much sense does that make? So if you work at OMH clinic, for any of you that worked in OMH clinic, you know you can't do substance abuse work in your clinic unless you have a separate license to do that, right? And then you can't do any primary care unless you have a separate license to do that, right? So those are 3 different state agencies that look at healthcare in a silo, look at mental health care in a silo, and look at substance abuse services in a silo. And so what we're trying to do on the national level is really encourage people to integrate behavioral health care and primary care, and we're giving them money to start doing some of these models through SAMHSA, which is a Substance Abuse Mental Health Services Administration, and HRSA. We've been funding what we call primary care behavioral health integration kind of demonstration grants. And so they'll give money, and maybe this clinic, we can talk about the name of it, they may give guarantee, where we give them money to kind of do these projects, where you partner with a primary care organization and you try to integrate your services. So it's not just, okay, we're referral based, we refer our patients here to this mental health clinic, but it becomes part of the patient's record, right? We have one electronic health record, and you see your primary care provider, and then you see your behavioral health specialist. That's all one system, and it's actually integrated versus just a referral kind of setup where there's 2 different people overseeing it. And so those behavioral health providers become part of the overall entity, and so it's either the primary care coming into the behavioral health or behavioral health going into the primary care piece. But it's just to kind of integrate that and make it seamless. Because really, you know, if somebody's coming into the doctor's office and they're complaining about aches and pains and all this other stuff, and the doctor's done everything, can't find anything wrong, you know, maybe you should see a therapist. Maybe you should go and talk to someone, because they have an idea that it's probably psychosomatic, right? Or something is going on with depression.
They're looking for evidence-based work where they feel that family therapy is really going to meet the needs.
Oh, absolutely.
You know, that it will be more effective in most of these cases than individual therapy, and they feel that it will meet the needs of the people overseeing it to be evidence-based. They're just looking for results and things
Right.
like that.
And so part of those grants are reporting back on outcomes, right? And I think we already know this, but what happens is if you say to your patient, go see a therapist, okay, how do I do that? Go on psychology today, or what happens? And so if you provide the seamless care, where now I can just send you to the therapist, the family therapist that's down the hall, or we can schedule your appointment right now so you can meet with the family therapist, that's integrated care versus go see a therapist and figure out where they are, and if they take your insurance and all that other stuff, right? So that's the way that we are asking people to move, but again, we can't dictate anything. The government kind of, at our level, we really say, you know what, we're going to support this, and we do a lot of it through demonstration grants because we don't have Congress hasn't necessarily approved for these ongoing programs, so we'll do them as demonstrations to see how they work, and then they may be time limited, maybe 3 or 4 years, and then people, if they find ways to make them work, can find different ways to fund them. But it really is kind of like a model. Hey, we think this is really great in terms of quality care. Here's some money, see if this works, let us know, give us some evidence that this works. And that's kind of how those things happen. And at the community-based level, you're going to see it a lot, especially if you're at Mercy, you're going to see a lot of those things.
Sorry. I always get confused with who's setting the standard of care. You know, is it the state? Is it the insurance companies? Do they default to the insurance companies? I don't know. big topic, I know, but I don't know if the Affordable Care Act touches on that, the standard of care, how they measure it. If we'll be doing treatment reviews or whatever, OTRs or whatever they used to call them. Remember those? So I don't know if there was anything about that.
So the way it works is that the federal government puts out standards. The CDC will put out standards around prevention, NIH will put out standards, SAMHSA will put out mental health standards. With us, with our community health centers, we put out standards around clinical operations, performance indicators, things along those lines. So I'll just give you an example from my agency because I can speak for us. With our community health centers, part of our job in the region is that we actually go out into the health centers. We look at their clinical operations. We look at their outcomes. So if you have diabetic patients, right? How many of their hemoglobin A1Cs are above 7 or less than 7? When we look at their hypertension and we look at all of those numbers and their outcomes, and we say, hey, you know, you have too many diabetics that aren't managed, or you have too many people that are hypertensive that aren't on the medications. I mean, we go in and we look at that. And if they're not meeting those clinical quality of care standards, then they can be defunded. And these grants, especially in New York City, are huge. I mean, they're over $1 million. I mean, the small grants are in Brooklyn, and they're like a couple $1 million. Manhattan, huge. I don't know if you all know Ryan Community Health Center, that's one of our major ones. We have, just I can name a lot of them in Manhattan. And so that's how we hold the standard of care. If you're part of JCO, which is the Joint Commission, which also does accrediting for our healthcare organizations across the country. They accredit hospitals, et cetera, et cetera. One of the ways that that works is that we will give our health centers credit if they're accredited by these organizations. And the accreditation standards are overseen by the government. We can't force them on them, but we recommend that they are. And so really what happens is these entities look at us for the standards, and then they implement them on their own. But again, it's a fine dance. We can't really tell people what to do at that level. Because we're not a dictatorship, we're a democracy. But
So
you know,
it ends up
people
being
look at the government to set those standards.
Right.
And so that's what NIH, you know, all know the National Institute of Health, NIH, all they do is research. We get a lot of our information from grants and demonstration grants and what people are doing and implementing to see if things work. The federal government will support those type of things.
So for private practices, then it does come down though to the insurance companies to kind of monitor the quality of care, you know, how they check in and they want to see, you know, they want to do a clinical update and that sort of thing. So it's really on the health insurance company.
If you interact with any insurance companies, you know that you send in all of your information to those accredited organizations as well.
Right.
And so they're rolling up all of their data and reporting it back to the state, and
Okay.
also reporting
So
it to
there's
the
a dialogue there.
Yeah, there is a dialogue around that. And if you're not meeting certain standards of care, you can be dropped from an insurance company. Doctors can be, we can be, you know, at any time we can come in and look at our files. TRICARE can say, you know what, I'm showing up now, you know, knocking on the door. We used to do unannounced site visits with some of our health centers with JCO. Like, it was hard to do it because we have to plan for the visits, but we would just show up at 8 o'clock in the morning, and we would be there for 4 days. And they would act like they're happy to see us, but they wouldn't. You know, but that's the expectation. You know, so at any time, they can ask for my files. Send me the files on XYZ client. And I have to send them. And then I hope they're up to date. They are.
Yeah.
Right?
I was going to just say that I had my clinic in Texas, we had a visit from United Healthcare, and they wanted to check fire exits and everything, you know. They just looked at everything, and there was a checklist, but they let us know ahead of time, so we had a chance to prepare. And then one of my fellow colleagues was audited on one of her particular clients, and they were checking to see whether her family sessions were family or whether they were individual, because it was a slightly different reimbursement.
Oh, wow.
So they can do.
Sure.
And the thing is, really, you know, at the federal level, we're not checking for fire exits. I mean, if we see something, but the state, really, they'll show up, just like they do with the health department, you know, the ways, all the restaurants, they'll just show up. It's just more efficient to not tell people. We walk in, and with our health centers, they have to have sliding fee scales available to all the patients, and it has to be posted. You know, we'll walk in and it's posted like right behind that little thing over there. You can see it. I'm like, you know, I can't see that. I mean, I have to do this. I don't know, it's usually not there, we just put it back, you know, those type of things. But, you know, that's just how it works. We can't be everywhere at any given point, but we try to have these things in place so that people understand that there's an expectation. All right, guys, I'm not gonna keep you here all morning unless you have any other questions. I think everyone has, I'm sorry.
I have one question, maybe a short one. You're so well versed on all of this. Can you give a personal prediction 7 years out?
No. Because I don't know who the next president's gonna be.
That's true.
Let me turn off the
And you can turn it off now.